All right, we'll go ahead and get started. Thank you so much for joining us today. This webinar is on accessibility and health for women with mobility disabilities and preconception education for people with mobility disabilities. Very quickly, just a note about ASL interpretation and captioning. We are providing both today, and you can spotlight the ASL interpreter if you need them. And please feel free to message us if you need some help with that. Very quickly, this webinar today is funded by the National Institute on Disability and Independent Living and Rehabilitation Research. But our views today are those of our speakers, not of our funder. And my slides are stuck, so I'm going to work on that. But I just wanted to say very quickly, we are the National Research Center for Disability and Pregnancy Research, and our quarterly webinars are a part of a broader array of research and activities that we do under this rubric of disability and pregnancy, which is an often overlooked topic. I'm going to very quickly read the bios of our speakers, and then I'm going to hand it over to our first speaker. Dr. John Harris specializes in obstetrics and gynecology and is certified in obstetrics and gynecology by the American Board of Obstetrics and Gynecology. He practices at University of Pittsburgh Department of OBGYN and is affiliated with UPMC Presbyterian and UPMC Magee Women's Hospital. He completed his residency at the University of Kentucky College of Medicine and did his medical degree at the University of North Carolina. His clinical interests focus on general women's health for women with physical and intellectual disabilities. He will be our second speaker today. Our first speaker is Karen O'Brien Kern, and she is a contributor at Able News. She is a writer, a speaker, and a mom of two who has been active in the disability community for almost a decade in roles ranging from mentor to project manager to parenting blogger. She is passionate about our community members defining our own independent lives and finding the support we need without sacrificing the understanding and respect that we deserve to get it. And with that, I am going to hand it over to Kieran to share her story about everything she went through in terms of preconception health, all the way through pregnancy and parenting. So Kieran, I'll let you take it away.
Amazing. Thanks, Nicole. Hi. As Nicole said, I'm Karen O'Brien Kern. I'm a writer, I'm an advocate, and I'm a mom of two amazing kids. I have spastic quad cerebral palsy and fibromyalgia, and I'm an ambulatory scooter user. So inside the house feet, outside the house wheels. I have wanted to be a mom since I was 3 years old, and it was not a phase. It survived my veterinarian phase, my fashion designer phase, and my high-powered lawyer phase. Preschool me shared this goal with my mom. That's who you talk to. And she promptly squeezed my chubby cheeks and told me I was adorable. It was true. But fast forward to 7th grade, and I wanted to babysit like my friends were doing, my able-bodied friends were doing. And she told me in no uncertain terms, no, and asked me the question, how are you going to take care of a child? It wasn't a malicious question, but she couldn't see the possibility of me being capable that way. So after that, I kept my child-centric goals to myself. But it remained in the back of my head that if I found the right person to build a life with, we'd have kids. So years later, I did meet the right person. And he and I, as we were discussing If we want to get married, we had the discussion, do we want to have kids? How many kids do we want to have? How do we want to raise our kids? All of the critical discussions you're supposed to have before a ring goes on your finger. Nobody asked me before or after if I wanted kids. I don't know what they were assuming. However, upon learning that my husband was going to propose, somebody he knew said to him, "So, you're not going to have children, right?" Now, I've been having random people make sweeping generalizations about my life, my ability, and my future, probably since I was diagnosed. That's the funny thing about disability, about living with a disability. So many people who know so little about you, your heart, your mind, your ability, feel the inherent need to tell you what you should be doing. It didn't bother me as much as it steeled my resolve. We'd be parents in our own time. And just, I don't know if it's me, but growing up as a disabled kid, as a disabled person, I figured that if I was upbeat, if I was positive, and if I was accommodating to the doctors, nurses, and therapists, they would want to help me. It just, happy, sunshiny kid coming in the door. And all of that worked until I was about 23 and I had a run in with an OBGYN. I have PCOS and I was trying to get support, information, and solutions for the things that were going on in my body. And I was met with derision. There I was sitting on her extremely high table. I don't even remember how I got on this table, wrapped in a paper dress, and she treated me like a parasite. She didn't even look at me. She took her notes, made some sweeping generalizations about how I took care of myself, and left the room. And at that point, I realized I would have to be assertive and unwavering in advocating for my needs. So I picked better doctors. They saw me as a person. They engaged me. They liked me. If they didn't pass the vibe check, they didn't come into the care team. However, as a disabled person, I always feel the need, even now, and I argue with myself internally, to put that superhero cape on, to be 10 feet tall and bulletproof. So when I asked questions about having children in the yet to be determined future, they were brushed off. Oh, don't worry about it. You'll be great. It'll be cake. That wasn't what I was looking to hear. And life has taught me to be over-prepared, to gather all my information, to do the work, to get the reward. And nobody considered the physical realities of CP. I don't know if they just, other than me, how many patients they'd had. But God bless my sister. And she didn't know anything of this was going on. Remember, everything was on lockdown. God rest her soul. She found out that there was a women's wellness rehab program at NYU Langone. And I looked it up. I found a doctor whose face I liked. And I booked an appointment. And it was revelatory. Her energy matched mine. I felt safe asking the questions that went past, "Oh, you'll be fine." Questions like, what muscles are involved in being pregnant? I.e., what do I have to strengthen? how do I prepare? How does pregnancy affect my cerebral palsy, my fibromyalgia, and my arthritis? So, after a thorough and respectful exam, she prescribed me regular physical therapy and pelvic floor physical therapy for holding of babies in bellies. It was refreshing. Finally, a medical professional took into account the answers I needed to feel secure in moving ahead. And my PT practice, they were champions. I had been with them at this point since I was 25, so for over a decade. And they were the only ones I shared my goal with. These were people that put their hands on my body 3 times a week to stretch me and help me get strong. They were my hugest cheerleaders, and to this day, I truly value how they supported me. On the home front, my husband and I were eating super healthy protein, fruit, vegetables. I was taking all the vitamins. I was moving and exercising regularly. We looked great. After 6 months of trying without success, my advanced maternal age enabled me to try fertility treatments. We decided to try IUI, intrauterine insemination, because the chances with IVF were relatively low for a relatively high expense. So that was going to be our last ditch effort. I did actually have to postpone the procedure because I had mobility needs that needed to be addressed. I needed cortisone shots in my knees, and cortisone in babies are not simpatico. Uh, the doctors at the fertility clinic were really supportive, very motivated, really great. And one of the realities of that environment is that you go to blood work all the time at like 6 a.m. You are not caffeinated, and they are sticking needles in your veins. And I will say the phlebotomy team asked me a lot of personal questions. Um, but they were all while also physically assisting me into the phlebotomy chair. I walked into the clinic with my husband. Um, Things like, who's going to help you? How are you going to take care of the baby? And my favorite answer, my glibest answer, was on the job training. But usually I just said I had a plan because I did. I always have a plan pretty much for everything. So after a gauntlet of blood work and medicine and giving myself shots in my stomach, I did get pregnant with the clinic. But sadly, I miscarried. However, on our month off, while we were waiting to start the process all over again, I found out at a 6 a.m. ultrasound that I was pregnant. At first, I thought something was wrong. The doctor said, "Oh," and I'm like, "Oh my gosh, what's wrong?" Because at this point, everything had been like a fail. And he said, "You're pregnant." And in my incredible eloquence, I said, "Really?" Um, we were excited, but we didn't tell a soul. I didn't want to get anyone's hopes up in case things went south. My first trimester was exhausting. I came home from work, I napped for an hour every night, but my mobility was unchanged. I could walk unassisted. The beauty of it is my fibromyalgia was suppressed, which is super magical. I had little to no pain. The second trimester was fantastic. I just lost my spot. I could literally get on the floor to clean. This is not something I did at all before pregnancy. There was no getting on the floor. And the first 2/3 of my third trimester, I had swelling, which challenged my mobility. I was moving slower and had hip pain from the tendons that try to loosen to prepare you for labor. Um, the labor I sought to avoid. I also had 2 ER trips during this time. The first was for heart palpitations. My in laws, thank God for them, dropped me off at the hospital, and my husband was on the way. So, alone in the ER, waiting to be seen, med techs prodded me with all the same questions. How are you going to take care of a baby? You. But funny enough, when my husband came in, my able bodied, very tall firefighting husband, the intrusiveness stopped. The next ER trip was the morning we were supposed to go to what I like to call the don't break the baby class. The night before, in a classic CP move, I'd fallen while getting into bed, and I landed on my husband's shoe. My rib cracked, or ribs. Um, I was in level 10 pain. I still did try to get to the class. My husband had other plans for the ER. In both trips, I was nervous, but to try to convey that superness, the self-assuredness that, like, I got this, I can do anything. I didn't want anyone to doubt me in that medical arena, that I was a professional woman who could get my stuff done. We did eventually get to the don't break the baby class and the breastfeeding class. And while I was the only wheelchair using participant, no one said anything to me about it. And to be honest, I think most people were just focused on their own experience, which honestly assuaged a fear of mine. I'm always prepared to be confronted, but I really don't want to be. The instructors were very informative and answered my questions without offering any intrusive opinions. My OB practice was fantastic. I had switched OBs to have my baby at the hospital I wanted to, and the team really supportive, but I was one of their very few disabled patients. However, they listened to and addressed my needs. What they didn't know about, they researched before prescribing me anything. So in the third trimester, after cracking a rib, actually in the third trimester after my hip started to loosen, I was in tremendous pain. And they prescribed baby-safe medicine for me with the instructions to use it sparingly. I never intended to be in labor and was fully committed to my C-section. I wanted the safest, easiest, most drama-free birth for my child. However, she had her own plans. So after a weekend of my husband working and painting and me sitting in a rocker holding my belly, I awakened at 36 weeks and one day to my water breaking at 3 a.m. I was so disappointed not to have sleep. But since we planned the C-section, we didn't do any birthing classes. So I said, I think my water broke. And then we Googled it because we had no clue. I called the doctor, and it was his backup, which my nerves were already jacked sky high. And he asked me if I wet the bed. I think maybe he was trying to cut the tension because I said, dude, I haven't done that in a solid 30 years. On the car ride over, I was gripping the car door because I was in labor and swearing that the doctors would send me home, that I couldn't possibly be having a baby before my due date. My husband's like, think you're having a baby? I was like, be quiet. I'm telling myself what I need to do to get there. We didn't even have furniture assembled, and I was doing labor breathing that I had seen on TV. So when they finally rolled me into the OR, Sade's Smooth Operator was playing on the sound system, and I was like, everything's gonna be okay. Sade says everything's gonna be okay. The nurses asked me about books and my cats while I was doing my spine block, and as soon as they numbed me, they got to work. My baby was born right before shift change, and though she was premature, she was big enough to avoid the NICU. 3 years later, we decided to try for another. Again, my OB team was fantastic. I'd already had a successful pregnancy and parenthood, but I was older. So after a year, I was about to give up. We had been doing all the right things, eating healthy, exercising, but as my husband was getting more fit, I finally noticed that my abdomen looked weird. And I figured I should take a test because I remembered my abdomen looking weird with my first pregnancy. And lo and behold, I was surprise pregnant again. So the first trimester was exhausting. I was trying to parent a 4-year-old. I was trying to sleep, and I will say I was still a lot more mobile. But by the second semester, she was bigger and she was laying transverse across my hips. My mobility was tanking. Thankfully, I was working from home. I went into labor the first time at 31 weeks and was sent home. Thankfully, they stopped it. And then I went into labor again. I started having contractions rather at 35 weeks. Anytime I moved, I went to the L&D twice. They sent me home both times, particularly after I asserted that the only way the baby was leaving my body was through my abdomen. However, at close to 10 p.m., a hair's breadth away from 36 weeks, we headed to the hospital. It was time. I felt like I was in a vice, completely different than the first labor. She arrived 2 hours later. Both times I was going to breastfeed. I tried to breastfeed my first child, and that was very unsuccessful. And this time I figured I would try again. And I was listed as needing breastfeeding support or feeding support. And the nurse on the shift of my first full day in the hospital took that to mean that I needed her to bottle feed my baby. Not so much. But it took about 2 rounds of feeding to explain that I wanted to feed my child, and she was just supposed to be there to help me with like holds and positioning. Um, I hybrid fed because again I wasn't making a lot of milk. Um, and the first time I had a baby here with my first daughter, I only had other able-bodied parents to ask questions of. And I will say they were amazing, but it's different experiences. My nursery was gorgeous, but the setup exhausted me. I had to cross the house to do everything, washing her in one room, diapering her in another room, feeding her in a third room. The second time around, I had found a group on social media of other moms that had CP, and it was revelatory. I made a mission control setup in my kitchen. A rolling bassinet was weighted down so I could roll her around the house more easily. A changing pad was on my kitchen table along with a bouncy seat and my computer so I could work. I was still working. Eventually, the high chair would join the party. I realized that with my first child, it was easier to move her around the house in a high chair. I nerfed skin to skin by wearing a zip up hoodie and zipping her in so we would both be warm and we would both be held. And the we adapted. I adapted my space to make it function, but my big surprise was how she adapted. And at 2 months old, she learned to stiffen her body to make it easier for her to lift. Disability in my house, it's our normal. My kids don't know anything else other than having a mixed ability family. New parenthood isn't easy for any parent, disabled or able bodied, but it is possible for every ability. By taking your stock of your needs in pregnancy and in planning and in childcare, as a parent, your environment, and the needs of your baby. Thank you.
Yes. Kieran, thank you so much for sharing your story. Um, we're going to leave 5 minutes at the end for questions as well. So if you have questions, please feel free to put them in the Q&A or in the chat. And I'm going to hand it over to Dr. John Harris.
Thank you so much, Kieran, for sharing your story. I'm going to go ahead and start about discussing about how we can be best prepared for pregnancy for people of all different abilities. I do always want to start with an acknowledgement of the Center for Women with Disabilities at Magee Women's Hospital here in Pittsburgh. It was started by Dr. Sandra Wellner, a physician who developed mobility and sensory disabilities as an adult, really led an amazing life and helped start our clinic. I work with a number of talented individuals in the medical and nursing fields that make our clinic a great place for all people. Always want to acknowledge NIDLR and their funding of the National Center for Disability and Pregnancy Research. I am at one of the many institutions that works with the Lurie Institute, Lurie Center to do this work. So I'm excited. So I want to get started. What are the problems for people with mobility disabilities before and during pregnancy? And how can preconception education improve health and pregnancy outcomes? So in terms of audience, I'm going to speak to hopefully to both audiences. One, individuals with mobility disabilities that might be listening in and trying to understand a little bit more about how they can best be prepared, as well as providers for these individuals and how we can do a better job. So there are a number of significant health and system issues related to pregnancy and disability care. You know, for individuals with disabilities, as Kieran talked about, it may be difficult to see other individuals around you that are making the same decisions, thinking through things with the same set of personal perspectives and issues. And for providers, sometimes we feel like this is an area where people are, that this may not be a very common issue among our patients. But I want to dispel that in that there's a variety of different numbers that we can define in terms of disability. But I think if you use individuals that have a significant disability requiring significant amount of accommodation, so please don't, many people may use a cane or braces or other things, but if you look, about 12% of reproductive age women have an intellectual disability, sensory disabilities, or a mobility disability requiring significant accommodation equipment. Now, among these individuals, the rate of certain preconception health issues, so pregnancy issues or issues with someone's health before they become pregnant, is higher in people with disabilities than with people without disabilities. So these are slightly different groups of people that we want to take really good care of. So you can see a variety of different health behaviors and medical diagnoses might be different among these different groups. So that once again, this prepares us for doing a good job for preconception education. Now, unfortunately, the care that people receive, as Kieran had some experiences with, thankfully, a lot of good providers, but some negative experiences, there's other research that's also shown negative research out of the same providers, out of the Lurie Institute, showing that among individuals with disabilities who are pregnant, that they had reported a fair amount of difficulty finding a provider. Often the provider had negative reactions to pregnancy, and they perceived that the provider's knowledge about disabilities' effect on pregnancy was really low. So these are all things that we're going to need to overcome to do a better job. Now, it's not surprising that in the setting of some system issues, of increased medical complications, of other things that are already there, that pregnancy outcomes may be, there may be more risks in pregnancy. So you can see there's a wide variety of both medical and social and financial things that may be different for people during pregnancy. And these are all important to realize that preparing people for pregnancy are great ways to help prevent and reduce the risk of these things. And then, of course, at the end with delivery and pregnancy and postpartum outcomes, you can see that there's a variety of differences. Depending on the study, the C-section rate is going to be the same for people with and without disabilities, but that's a personal decision that we always make for everybody about what's the best way of delivering people, but there's also some disparities in postpartum care as well. All right, so then the wrap up from all of this is the best way to help reduce the risk for these things that we know is out there, to help have a healthy pregnancy, birth, and postpartum period, is to be as healthy as possible and to be as prepared as possible and to have the best team before becoming pregnant. So that's the idea behind a preconception visit. Typically, a preconception visit is focused on individuals who are becoming pregnant in the next year, in the next 12 months. Now, I think it's very important, especially for individuals with disability, to consider a wider interval of time. So maybe that might be the next 5 years or the next 10 years, but we want to have these conversations so people feel more empowered to make these decisions for themselves. So the basic goals of a preconception visit are there's 3 different topics. So first, we want to screen for potential risks to the person planning to become pregnant and for their fetus. We want to educate them about other potential risks, options for interventions and management to reduce those risks before pregnancy, and then initiate interventions that help provide optimum maternal and fetal health before pregnancy begins. As a part of this, and as a part of our research here in the center, I want to talk about designing and testing a tailored preconception education intervention for women with mobility disabilities. Well, again, we're thankful for NIDLR's funding of this, and we focused on individuals with mobility disability. That would be a wide spectrum, and we tried to make this very inclusive, but certainly that might include people with a spinal cord injury, spina bifida, cerebral palsy, rheumatoid arthritis, Ehlers-Danlos, and a whole other spectrum of conditions that may involve extra accommodations or adaptations in mobility. Our study had 3 phases. First, we wanted to discover, when we looked out into all the different medical research and literature that have been published on preconception education, what are the education topics, or I'm going to use the word, what are the education domains of preconception counseling? So we created a big long list. Next, we used what's called a Delphi study, which is a panel of experts, in this case 18 experts, who helped define what are the most important domains of preconception education that are important for this patient population, people with mobility disabilities. And then we use those focused areas to do a pilot intervention where we educated people with disabilities on those so that we could see if they felt more educated after our intervention. So to give you a little sense of that, we started with 53 very different types of education that could be provided for people for preconception, for people with mobility disabilities. So some of these things were very specific, like management of autonomic dysreflexia, and other things would be very general, like nutrition counseling. In terms of our experts, you can see that they were a diverse set of people with disabilities, without disabilities, people of different training and expertise, as well as people from across the country. So what did we find? Well, we found 13 important consensus education topics, and of those topics, the first 9.5 of them are topics that would be considered general preconception education that would be included for all people. So understanding pregnancy intention, understanding someone's history of infertility or obstetric or past pregnancy history, their own genetic and family history, understanding their medical history, their medication history, their mental health history, nutrition and weight history, social determinants of health, so a variety of different social factors that improve or can make health more complicated, and intimate partner violence screening. We also identified a number of specialized domains that were more significant and important, especially for people with mobility disabilities. So that includes screening for caregiver abuse, functional mobility and physical accommodations, musculoskeletal and skin health, bowel and bladder surgery and health, and neurological and neurosurgical health. Again, not every individual may need all these topics, but it helps us as providers to kind of think through all the different areas that would be important to cover, and also to have a good knowledge about how a particular person's history, mobility, medications may affect preparing for pregnancy. So we use those 13 domains, and we did a preconception education intervention or experience for people with disabilities. So we worked with 26 participants who had a mobility disability. We covered all of these domains in a nurse-led telephone call to cover people's experience. We used a research-based educational method called the representation method, and the calls lasted about an hour. So they were a significant amount of time. You can see that our research Participants were a diverse set of individuals with lifelong or acquired disability from a number of different causes, and were a diverse set of individuals. And if you look on the right-hand side, you can see that before and after preconception, after our intervention, preconception education increased greatly. And we compared that to just general health knowledge. So we would expect that our general health knowledge would be the same because we were covering a very narrow spectrum of health, but that narrow spectrum of health is thankfully increased. So this was a good feasibility trial to show things. Finally, our next step in the coming years, and we're thankful for our funding from NIDLR to do this, is a larger trial to test the efficacy, how well this actually improves people's health knowledge and self-control of preconception health compared to usual education. So this is a randomized control trial that's in progress. And if you're interested in participating, please reach out to the Lurie Center. All right, so for those of you that are now thinking, okay, so what does preconception education entail, and how can I start to be prepared for this and reach out to providers, or as a provider, how can I do a better job of doing this? I'm going to talk about the general preconception health, and then I'm going to talk about the specialized things that are especially specific to mobility disability. Now, I don't want to overly separate these two topics. To understand medication history well, it's important to understand the common medications that people may be on with different mobility disabilities. And for those of you that have a mobility disability, you may need to help your providers become more educated about what it looks like to have a baclofen pump, or what medications that you take periodically when you have a flare of your condition related to your disability. For other things, it's just important to get the general counseling about what's the right vaccinations and things like that. But there's also going to be some specific questions that may not typically come up in a preconception visit that I'm going to cover as well. So the first thing is learning is a good history for this interaction. And so that history will include a set of medical problems and history. Now, those may be related to your disability. They could also be general issues like asthma or diabetes or thyroid problems. Surgical history is always important. For some individuals, their surgical history may be relatively complicated, and it might be important to understand what surgeries you've had and how they may affect things going forward in pregnancy. Will some of those surgeries affect the spinal cord, and may that make it harder, or may we need to think about anesthesia earlier on in the process, even before pregnancy? Maybe we need to talk with a neurosurgeon because maybe someone's had issues with having a shunt that hasn't worked properly, and making sure that we're as prepared as possible before pregnancy. And it may be that someone's had extensive urologic surgery, and it's important to understand exactly how someone's bladder may work with a growing fetus during pregnancy. Other things that might be important would be understanding substance use, trying to make it so that people are not using alcohol, tobacco, or other vaping products before and during conception and pregnancy, thinking about nutrition and exercise. Kieran says that it was very important for her to have great physical therapy treatments and to feel as strong as possible, as flexible as possible before pregnancy. So that's an important thing to cover. Mental health is very important for all individuals to be prepared for in pregnancy, as pregnancy and the postpartum period are sometimes times where this becomes extra hard, and people can have new or exacerbating episodes of depression or anxiety, and then managing, screening for, and improving social determinants of health. After a good history, there is a physical exam that's often included as a part of a preconception visit. That physical exam is doesn't have to be very extensive, but certainly that might include a general physical exam, measuring blood pressure, height, and weight, and testing for things like infections or diabetes or prediabetes, just some basic testing to make sure that we're people as healthy as possible. Now, that third part is then offering interventions for people that are considering pregnancy to improve their health before they conceive and become pregnant. So some common interventions for all individuals considering pregnancy in the preconception time period would be starting folic acid supplementation. If someone has diabetes or prediabetes, managing those conditions. stopping alcohol and drug use, stopping tobacco and other inhaled agents like marijuana, THC, and vaping, getting up to date on vaccinations. There are vaccinations that are only available for people before they get pregnant. And then once they become pregnant, we do not give those vaccinations until afterwards. So a good example would be the measles, mumps, and rubella vaccine that is a live vaccine that we give before pregnancy or after pregnancy, but not during pregnancy. Other things that people might feel more comfortable receiving those vaccinations before pregnancy, like a COVID-19 booster, and they may have some concerns taking it during pregnancy. So that's another time when we can optimize things. Thinking about weight management and good nutrition, optimizing medications. So that may look like looking at the medications you're on and understanding whether they may cause, they may be teratogenic or cause changes that are avoidable in the baby's development, or thinking about medications that simply are not well studied in pregnancy and thinking about how we could manage those and avoid those where possible. And then treating common medical conditions like high blood pressure, asthma, and thyroid disease so that people are as healthy and optimized before pregnancy. And then once again, screening for and treating those mental health needs so people are as healthy as possible. Okay, so I talked about those general things, and I hope I talked a little bit about how we would personalize that for an individual with a mobility disability. But now I want to talk about those specific things that are going to be most kind of a highest yield and most specific for people with disabilities. So that could include assessing functional mobility and physical accommodations. So understanding what accommodations and equipment people use for their daily mobility can help us think about how pregnancy might change those accommodations, how we can be best prepared for the changes that might happen in pregnancy. Obviously, with pregnancy, people will have a change in their center of gravity with the growing baby. They may have a change in weight and a change in their relative strength. Some people have more fatigue in pregnancy. And so we want to be able to modify people's existing accommodations for any changes in mobility and strength that might happen during that. Next, we want to assess musculoskeletal and skin health. So to me, what that looks like is, once again, understanding issues around muscles, around spasticity, around fatigue and chronic pain that may come up or be exacerbated or may be more challenging in pregnancy, and thinking about that. Once again, pregnancy is an area where people often will gain weight, and they may put additional stress on certain areas of skin. We want to avoid pressure injuries. And so making sure that skin health is as great as possible over those high risk areas before pregnancy is really important to optimizing it during pregnancy. Next, managing bowel and bladder health and surgery. So many individuals that have mobility disabilities may have specific bowel regimens, bladder regimens to help manage those things. Unfortunately, in the pregnancy period, constipation is more common, and so that can exacerbate or challenge existing bowel regimens for some individuals. So we want to have a plan for how we will intensify regimens to make sure that people are regular and comfortable throughout pregnancy. And then for bladder health, we want to make sure that people are comfortable. We want to make sure that their bladder regimen works for them. Once again, that we have plans for if there's any increase in incontinence so that people's skin is healthy. Also, if people have common UTIs, how to prevent those during pregnancy, as frequent UTIs are associated with preterm labor and birth. And then also thinking about previous bladder or bowel surgery and how pregnancy and the change in their uterus and their bodies may affect those bowel surgeries to help prepare them for pregnancy and a healthy pregnancy. Next, neurological and neurosurgical health for individuals that have a neurological condition like multiple sclerosis. We want to prepare people and have their medications as best optimize, their kind of therapy plans set up so that they know, okay, I'm going to get my disease modifying therapy injection at this point or infusion, and then I'm going to try to conceive for this amount of time. And then maybe if I'm not pregnant, I'm going to go back on contraception. I'm going to get another infusion, then try again a little bit later. These are plans that we want to work through early on. And then, as I talked about already, neurosurgical health, maybe just understanding how to best be prepared for some people that have a history of needing neurosurgical interventions, on how best to be prepared for that. This also may look like things like understanding what we're going to do with the baclofen and pump and things like that, about, once again, how to be prepared for pregnancy. And then unfortunately, as we should screen for intimate partner violence in all individuals, we want to also screen for the specialized issues that sometimes come up with the complicated relationships people might have with not just their intimate partner, but with other caregivers and family members, looking for caregiver areas of abuse and coercion. Pregnancy may be an area where there's going to be conflict between all these teams, and we want to identify issues early on and help manage them and come up with great solutions for people where they can maintain safety and be safe during the conception, pregnancy, and postpartum period. Again, thinking through that next stage of a preconception visit, which is the physical exam, what might a physical exam be? How could it be adapted to be more focused for an individual with mobility disability? So weighing mobility equipment, when we want people to receive regular weights throughout their conception and pregnancy period, that often will look like knowing the exact weight of someone's wheelchair and the things that are often attached to their wheelchair, so that they may not need to get out of their wheelchair at every visit, but we could get a weight at every visit just by using a wheelchair accessible scale. The person, rolling onto it, getting a total weight, subtracting the weight of their mobility equipment, and then we can track people's weight change very closely before and during pregnancy. Examining mobility equipment for potential fit issues. If your equipment is already a pretty tight fit for people, sometimes that's optimal. Sometimes it may mean that just the equipment's a little bit old and isn't the exact setup for where people need to be. We want to think about that because we know that there's going to be changes in your body to help prepare and help not have problems during pregnancy, or if necessary, just how we're going to modify equipment as people's bodies change. Again, for doing a preconception visit, I would hope that people are getting regular skin checks through a variety of different providers, but for someone that's maybe doing a pelvic exam, this is a great time to look at the health of people's skin over their hips and their tailbone and make sure that things are as healthy as possible. And then talking to people about hip mobility and leg mobility. There's no necessary hip or leg mobility for pregnancy, but it may be helpful if someone's thinking about what pregnancy and childbirth may look like, to think about what's the relative mobility and flexibility people have, and thinking about how that may change or be different, and how that maybe we start to think about a little bit about delivery planning, just so that's not an area of anxiety, but a rather area of clarity and surety. Finally, we want to think about interventions. So what are some specialized interventions that can happen for people with mobility disabilities? Now, one of the most important things that Kieran mentioned was a really transformative visit with a physical therapist who was very respectful and accommodating and helpful. And not only is that physical therapist appointment important, but it might be important to work with an occupational therapist to consider, well, right now I don't have complete access to my home, and I want to have access to an extra bedroom for a nursery, or be able to reach certain things so that I could care for someone. Occupational therapy may be very helpful, as well as bringing together all the medical and surgical specialists that might be involved in someone's care before people get pregnant, so that we can all be on the same page, make sure that we're not missing anything, and that everybody has a good plan for how we're going to adapt and optimize care throughout the pregnancy. Support groups are going to be very important for people that are considering pregnancy and thinking through this, and they may be another source of good advice about how to best be prepared for pregnancy. So there are, unfortunately, individuals that are not familiar with the amazing resources that are available, either in your community or in the online community, and we want to try to connect people with those resources. Prehabilitation planning, so maybe even getting extra healthy, extra strong, extra flexible before pregnancy is a great idea, just because pregnancy is a time that stresses everyone's body. And so if we can increase people's strength, then any relative decrease during pregnancy or the postpartum period, we're starting at a higher baseline. And then, of course, we'll also have good relationships that can go if people need any rehabilitation after pregnancy. And then there are certain interventions that are commonly known. So for instance, for someone with a history of spina bifida for themselves or in their family members, we recommend a higher dose of folic acid before trying to conceive. And this would be a very specific intervention that we do for people that have a history of neural tube changes and spina bifida that we can help improve and optimize health. In summary, preconception health education is a great way to understand your personal process for being prepared for pregnancy. This could mean being prepared for pregnancy in the coming months or in the distant future. But in either case, it's great to get kind of a holistic perspective about what this would look like for you and how to be best prepared for it. Preconception education should be offered to people with disabilities at the earliest stages of considering parenting and pregnancy to help overcome the unfortunate systemic barriers to decision-making and healthcare, as well as the absence of accurate and positive messages about disability, pregnancy, and parenting. And people with mobility disabilities need all the elements of traditional preconception health, but some additional focus or attention to physical function, mobility equipment, and previous bowel, bladder, spine, brain surgery and health may be helpful to help prepare people for pregnancy. Thank you for the opportunity to talk with you all, and we're happy to take questions at this time.
All right. Thank you so much, John. And thank you again, Karen. We have 2 questions in the chat, and they both are on the same topic. Can you share more about the caregiver assessment in terms of caregiver abuse during the pre-pregnancy visit? And are there any screeners, John, that you know of for this particular issue?
That is a great question. I will admit that I have not thoroughly screened all the available screening options out there. I hope that there are really good ones. I will admit that that all of the screening for these types of issues needs to be very personalized. And so first you need to understand the network of caregivers and partners and family members that may be, involved with things. So first you have to understand that dynamic. So you need to then assess with the individual, without those people present, if they feel comfortable with all these different things. Now, I will admit that everybody might have some tension. I mean, we all have a mother-in-law, or a family member that's extra opinionated, and we need to understand that, of course, there are these people who are going to have differences of opinions, but are they affecting, coercing, reducing care in a way? There are stories about people that said, I'm not going to care for you if you get pregnant, because they see that pregnancy and parenting will increase the amount of caregiving that they feel like that's necessary for them to. And of course, by saying that you're reducing, that's trying to coerce people in their own reproductive planning. So I would say that it needs to be very individualized from the perspective of the provider. You need to think broadly about what could be going on, and you need to really investigate those things. There are many people that this may be something where you can talk about it, but people will think about it and then think about whether they want to disclose it. Interestingly, intimate partner violence screening is somewhat controversial because we know that people will often withhold information. So sometimes the best advice is offering the help without making people self-disclose. So saying, if you ever have any questions or feel like you do not have the freedom to make these decisions for yourself, feel free to reach out to us, to reach out to a social worker, or to reach out to another trusted person to investigate that. So I'll admit that I don't know all the screening options that are out there, but I would say probably that the screening options are likely overly prescriptive for the nuanced situation that is there. But for a lot of providers, just realizing that you don't need to just ask about the intimate partner, but you also need to ask about the caregiver team, fortunately or unfortunately, will increase their perspective a lot.
Thanks for that. The other thing I just want to add really quickly onto this, in addition to being a researcher in the area of disability and pregnancy, I am also a person who uses a wheelchair. And sometimes the sexuality and the reproductive decision-making of people with disabilities, in particular women, can be pathologized. And it's really, really important to understand that while abuse is a huge problem within the disability community, especially for folks with intellectual and developmental disabilities, which may have a physical component. People with disabilities absolutely have consensual, healthy relationships. And we don't ever want to assume that just because someone comes to us and they're pregnant, we don't ever want to place value judgments on that pregnancy without hearing from the pregnant person themselves. And my screen is freezing up, so I'm going to be quiet now. But if you have other questions, please put them in the chat. And then very quickly, I just wanted to talk about mental health and the interplay between mental health and physical health for someone who has a physical disability. And I want to ask Kieran in particular, how did you negotiate that? How did you think about your own mental health while you had this physical disability? Or what sort of things helped you out in that particular area?
Well, this is a great question because I have had in life, I've had periodic depressions. I'm very aware and in touch with my mental health. During my pregnancy, preconception was very stressful. So that you kind of went from very high to very low. And I did seek out medicinal support at that time, which I stopped when I became pregnant. But what was kind of more harder to diagnose was with both, mainly with my first child, is I had postpartum. And it took me about a solid 3 months to figure out that I wasn't just tired. I had something going on. And at that point, I sought care. And with my younger child, I sought care earlier because I recognized all the hallmarks of this isn't just exhaustion. This isn't just the pressure for everything to be perfect. And there's a lot of that. In fact, actually, I spoke with John earlier, and I said that I felt, and to a point still feel, a degree to be flawless, to have no problems, so that my capabilities were not doubted. And that's a great deal of pressure to live with regularly. And I think it just speaks to being a part of a marginalized population. But I feel like when you're planning on getting pregnant or when you're pregnant, you need to consistently do like a self-check or have like your best friend or the person you feel the safest with having that discussion, say, hey, do I seem different? Do I seem stressed? Do I seem down? If you can't see it for yourself, to be able to take action, because it's, if it goes past a normal level, you have to maintain your own sanity first. It's putting the oxygen tank on you first before you can take care of even one other person, let alone everybody else. Is that good? Mm-hmm.
Yes, thank you so much, Kieran. That was a beautiful answer. And just as we're wrapping up at this 1 p.m. moment here, I just wanted to say thank you everyone for attending today. Thank you so much to our speakers, John and Kieran, for sharing your story and your research and all the work you're doing in this area. This webinar has been recorded, and the materials from this webinar will be made available to all attendees and be posted online for folks to be able to access. So thank you all so much for your time today. And again, thank you to our speakers, and I hope you all have a great rest of your day. Thank you.